Thank you for answering the pre-test. Hi, I'm Dr. Minda Lucy Manas. I have a training in child and adolescent psychiatry. Welcome to Understanding Depression. Our objectives today is to recognize the common symptoms of depression and its clinical features in children and adolescents. Also to know the management of depression and to increase our understanding of suicidal behavior. Before we get into the discussion of depression, let me ask you, are you mentally healthy? Let us have a glimpse of what mental health is all about. WHO revised its definition and states that it is not merely the absence of an illness. It requires certain criteria for one to be mentally healthy, and this includes the following. First, an individual should be able to realize one's potential. Second, one can cope with everyday stresses. Third, one should be able to work productively and fruitfully. And lastly, it is a very important criteria that one is able to make a contribution to the community. What is mental illness? These are health conditions and, mind you, medical conditions that involves any changes in one's thinking, emotions, and behavior that affects one's functioning, be it at school or work, or in other relational areas. It has been studied that 1 of 4 people will experience a mental health issue that can potentially develop into a mental illness. There are about 200 classified forms of mental illness. One of the most common, if not the most common, is depression. How do we differentiate the usual sadness we experience to that of depression? Feeling sad is a natural reaction to situations that cause emotional upset or pain. But like other emotions, sadness is temporary and fades with time. In this way, sadness differs from that of depression. Depression lingers longer. It is a mental illness. It impairs social, occupational, and other important areas of functioning. Left untreated, symptoms of depression may last longer. When we talk about clinical depression, we are referring to major depressive disorder. It is a mood disorder, a medical illness characterized by at least 2 weeks of low mood that is present across most situations. To make a diagnosis of MDD, the individual must be experiencing 5 or more symptoms during the same 2-week period of time, and at least one of the symptoms should be either 1. Depressed mood, 2. Loss of interest, or what we call anhedonia. Let's look into the other following symptoms. The other symptoms include sleep disturbances, changes in appetite or weight, and it could be both ways, either loss of appetite or increase in appetite, loss of weight or increase in weight. The next one would be concentration problems, loss of energy or easy fatigability, socially withdrawn, feelings of helplessness and hopelessness, and later on, recurrent thoughts of death and suicide. Although depression can occur at any time in life, symptoms may be different between the teens and the adults. Issues such as peer pressure, academic expectations, changing in bodies, and issues on self-image can bring a lot of ups and downs for teens. Like in the adults, there is significant distress and problems at school or home, in social activities, or in other areas of life. However, more than the depressed mood or low moods, there are other manifestations of depression among the children and adolescents. Let us take a look at the other features: irritability or anger, behavioral problems, drug use, sexual promiscuity, academic problems, preoccupation with morbid themes, heightened expression of boredom, frequent aches and pains. Knowing what can raise one's odds of depression may help understand the process of depression. All these stressors can increase the likelihood of developing depression. The experience of loss, lack of social support, stressful life experience, family history, trauma, abuse, neglect, alcohol and drug use, health problems, financial worries are all factors that can increase the likelihood of depression. What are some of the factors linked to depression? Genetics. A history of depression in one's family may make it more likely for a person to get it. Biological. In people who are depressed, the mood-regulating neurotransmitters don't function normally. Usually, the signal transmission through these brain chemicals is either depleted or disrupted. How about medications? Some drugs such as isotretinoin, those we use for acne treatment, beta blockers, contraceptive pills, the antiviral drugs like interferon alpha, and corticosteroids can increase your risk of depression. Dietary. Recent studies have been found that eating unhealthy foods, especially those high in sugar and fat, contribute directly to the biological and emotional states associated with depression. It has been studied that they are associated with the alterations in the brain chemistry and productions of serotonin. What about our environment? Pollution in our air, in the water, and the food definitely affects our body. Other non-chemical sources of environmental stress can include noise pollution, electrical pollution, natural disasters, and other catastrophic environmental events. Let's take a look at personality factors. Certain personality traits such as low esteem and being too dependent and overly critical or pessimistic traits are more vulnerable to having depression. Depression is definitely treatable. In most cases, treatment involves a combination of your medications, psychotherapy, and other techniques. Needless to say, a healthy lifestyle must be adopted to include changes in nutrition, adequate sleep, practice of mindfulness. Somehow, we have to try and strike some balance in our day-to-day living. Social connectedness is also very vital. We need to have healthy relationship with others, a sense of belongingness to a group or to a community. Connectedness to oneself also gives us a more meaningful life. Let's talk about antidepressants. Usually, we inform our patients that depression is explained simply as a chemical imbalance. But how exactly does the brain work? How do antidepressants improve the symptoms? In a healthy brain circuit, one neuron communicates with another neuron via brain chemicals or what we call neurotransmitters. In depression, this includes serotonin, dopamine, and norepinephrine. The most commonly prescribed antidepressants nowadays are called reuptake inhibitors. For one, there is the selective serotonin reuptake inhibitors or SSRIs. They work by slowing down the reuptake of serotonin molecules by the presynaptic neurons. Because a serotonin reuptake is prevented, serotonin molecules end up staying in the synapse longer than they should normally would and get more a chance to activate the postsynaptic neurons, which results to a balance and good mood as well as affecting the energy level, enhancing concentration, promoting sleep, and improving the other symptoms of depression. Selective serotonin reuptake inhibitors, or SSRIs, are usually the first choice as these have less side effects and are less toxic in overdose. In the absence of previous treatment, a generic SSRI should be usually the first line of choice. They are the most commonly prescribed antidepressants available in our market. They include fluoxetine, sertraline, paroxetine, and escitalopram. There are actually no significant differences in efficacy between the different drugs available to treat depression in adults as well as in children and adolescents. Although only fluoxetine has been shown in clinical trials to be effective in treating depressive illness among children and adolescents. The starting dose of 1 tablet once a day may be effective, and titration may not be necessary for most of them. Patients should be seen after 2 weeks or sooner, and then every 2 to 4 weeks to monitor the response to the treatment. How about maintenance? Patients should continue therapy for at least 6 to 9 months after recovery from a single episode. As in our practice guidelines, the choice of treatment is always based on an assessment of comorbidities, potential side effects, and safety in overdose balanced against expected benefits. Let's talk about suicide. In the next 40 seconds, there is one individual out there who will commit suicide. About 800,000 every year, individuals commit suicide, and the number is still counting. There are about 7 Filipinos a day who take their own lives, and suicide rate has increasingly been rising alarmingly in the Philippines. Suicide is currently the second leading cause of death among the age group of 15 to 29 years old. Males are 5 times more likely than females to commit suicide, and usually leads to a completed one because of the lethality in the means that they resort to, such as gunshot or strangulation. One other reason men are more likely to complete suicide may be because they are less likely than women to ask for help or express their emotions. The following factors will increase the likelihood of a person to commit suicide: a previous suicide attempt, abuse of alcohol or other substances such as drugs, any mental illness like depression, anxiety will increase the likelihood of suicide, access to lethal means, a family history of suicide, social isolation. While there are risk factors, there are also protective factors that may help lessen the incidence of suicide. Let us take a look at them. Effective mental health care and accessibility, connectedness, life skills, which include better problem-solving options, coping and adaptations, self-esteem, sense of meaningfulness in life, and sometimes even personal, religious, or spiritual, and even cultural beliefs may be part of the protective factors. Are there warning signs you need to be keen on to suspect if a person is thinking of ending one's life? Yes, there are. Any significant changes in behavior, including depressive symptoms, particularly feelings of helplessness and hopelessness, isolation and withdrawn behavior, anxiety, agitation or recklessness, increase in alcohol or drug use. Talking or writing about wanting to die, joking about suicide or death, giving away prized possessions, making final arrangements, and suicide plans. When someone says he or she is thinking about suicide, or says things that sound as if the person is considering suicide, direct questioning is necessary. We need to be very sensitive, but go ahead and ask direct questions such as, are you thinking about suicide? Go further and ask, have you thought about how or when you would do it? Do you have any access to weapons or things that you can possibly use to harm yourself? Asking about suicidal thoughts or feelings does not push a person into doing something self-destructive. In fact, offering an opportunity to talk about the feelings may reduce the risk of acting on it and the suicidal feelings. When evaluating a suicidal patient, immediate action should include removing the means for suicide and ensuring the safety of the patient and others surrounding the person. Stabilize any presenting medical condition and treat any comorbid conditions. Unless there is a serious medical complication, admission to a psychiatric unit is recommended. This is for close monitoring and to restrict the access to means and to start the therapeutic milieu. There are several approaches to suicide prevention. Increasing public awareness, educating gatekeepers, improving media coverage, reducing access to means, improving treatment, and of course, support for survivors could help prevent suicide. When someone discloses about suicidal thoughts, we need to educate others on what to say and what not to say to someone who is thinking of suicide. A simple statement of how much one cares about or love the person can help nurture a sense of connection. Sometimes it is not so much what we say, but what matters is that we sit down with them, we listen and hear them out. A simple statement like, I'm glad you told me. I am going to find someone to help you. Or stay with you until the help arrives. What you say next is very important. In general, these statements can convey judgment and foster alienation. Brushing off someone's struggle may lead them to feel invalidated, which can actually worsen the condition. We would like to emphasize on early intervention. So, please avoid saying, it's just a phase. Oh, go ahead and snap out of it. Stop being so selfish. You're just trying to get attention. Get over it. Be positive. It's all in the mind. We hope you can join us in this advocacy. What can one do for one's mental health? We can begin with trying to understand ourselves better, being good, being kind to oneself. We need to value ourselves. We have to introduce self-care to our patients. Pagmamahal sa sarili, pag-aalaga sa sarili, pagpapahalaga sa sarili. We have to try and teach them how to practice balance and spend moments of quieting their minds. Like it or not, stress is a part of life, but we have to teach our patients to practice better ways of dealing with the everyday stressors of life. People with strong family or social connections are generally healthier than those who lack social support. In summary, depression is a common and a serious medical illness. It can lead to a variety of emotional and physical problems which can decrease a person's ability to function at work and at home. We have discussed the symptoms, which may vary in its presentation among children and adolescents. Now we know there are several factors that can play a role in depression. Suicide as an end spectrum of depression is always a tragic event with strong emotional repercussions for survivors and for the families of our patients. It is quite a challenging task when it casts a shadow over the lives of our patients and their families. And we all have a responsibility. a responsibility to save life and prevent suicide. Depression is among the most treatable of all mental disorders. The brain chemistry may contribute to an individual's depression and may factor into their treatment. It is very important to remember that the treatment is effective. People who get appropriate care can recover and lead a full, rewarding life. Live well and be well. All for the Filipino child.